Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hey listeners, it's Lindsay Smith-Rogers. Today, what happens when the healthcare system sees a person's intellectual disability but misses their mental health concerns? Stephanie Desmon speaks to Dr. Dimitri Christakis, the Chief Health Officer at the Special Olympics, and former Special Olympics athlete Kayte Barton about the struggle to access mental health care for many people with intellectual and developmental disabilities. Let's listen.
Kayte Barton and Dimitri Christakis, thanks so much for joining me.
Thank you for having us.
So today I wanted to talk about some new research that was conducted by Dimitri. Adults with intellectual and developmental disabilities experience a much higher rate of anxiety and depression, yet many struggle to access mental health care. I wanted to start with you, Kayte. People hear mental health and intellectual disability in the same sentence. They may not realize how connected those issues are. Can you tell us a little about your experience with mental health and getting care?
Yeah, in 2009, I experienced some of my own mental health issues, and we tried to go get help, but my disability got in the way, so I couldn't get the help, which led to me reaching out to Special Olympics and the creation of Strong Minds.
What kind of intellectual disability do you have?
I am autistic.
I don't know anything about Strong Minds. Can you tell me a little bit about that?
Strong Minds is a part of our health initiatives that is designed to teach athletes coping skills, both for competition and in life. It teaches them how to use stuff like deep breathing, positive self-talk, and music or other things that help them calm down and help them focus on competition.
Dimitri, tell us about your new study. You found some pretty striking differences in anxiety and depression among adults with intellectual and developmental disabilities. What stood out to you the most?
Yeah, we did. And I want to say that Kayte's story is not at all unusual. In fact, it's quite typical of people with intellectual and developmental disabilities, which is to say that they can often struggle to find providers that will take care of them and help them. What we did in this study was a survey of U.S. adults. What we found was when we compared adults with intellectual and developmental disabilities to those without, that there were striking disparities. 51% of adults with IDD experienced daily anxiety compared to 8% of the general population, and 26% experienced daily depression compared to about 1.5% of the general population. So think about those numbers for a minute. They're quite staggering. There's an enormous disparity. And just like with Kayte, what we found was that adults with intellectual developmental disabilities faced significant challenges trying to get care. In fact, they were 5 times more likely than adults without intellectual and developmental disabilities to report delaying or foregoing care because of the cost barriers they faced. So we talk a lot in this country about the mental health crisis it faces our teenagers. And it's true, there is one, and hopefully it's getting the attention it deserves. But about 25% of U.S. teenagers have anxiety or depression. That's half as many as people with IDD. They too need to get the attention they deserve.
So for people listening who might not know much about this issue, why are the rates so much higher?
It's a great question. And it's like many things, it's probably multifactorial. People with IDD face a lot of societal challenges. They're frequently bullied. They're frequently ignored or overlooked. Their opportunities to fully participate in society are often limited. And as I mentioned, their ability to get the help they need is often hampered. So I think one of the things that we found and we're very proud of is that participation in Special Olympics itself has been found in a study done by Canadian researchers, not affiliated with Special Olympics. The participation in Special Olympics alone reduces the risk of anxiety and depression by almost 50%. So that alone tells you a lot. It tells you that the opportunity to be in an environment where you're physically active, as Kate was for many years, but equally important, where you're respected, treated with dignity, included, given opportunities to socialize with other people. All of those things are protective, and we need to have more such opportunities for people with IDD.
You've called this a mental health crisis hiding in plain sight. What do you mean about that?
Before we did this study, I don't think most people were aware of just how prevalent this problem is. And in part, it has to do with the fact that people with IED are often, as we say, invisible to others. When people see Kate, they don't necessarily see her disability at all, which in some ways is, of course, good, but in other ways, it makes it easy for them to overlook it. The challenges that she faced aren't as obvious as they would be if she walked with a cane, let's say, or was in a wheelchair, but they're no less real and they're no less important to her. Did I get that right, Kate?
Correct. I think having an invisible disability, such as autism, makes it more of a challenge because they don't see the disability and they just see me as somebody that's potentially normal, which is not the case.
Do you feel like, Kate, that providers focused more on your disability than your mental health?
Yes. And part of that is, too, that training for healthcare providers to work with people with intellectual disabilities is not covered in med school, which it needs to change on all aspects, including mental health care. So they are prepared to work with us when we come into their clinics.
I imagine you see plenty of doctors, but they weren't focused on the mental health part of this.
Right. Often they see a disability and they try to shove us out the door really fast.
Kate, there are two things you said I want to just offer my concurrence with. One is there is a tendency to focus on the disability and not the totality of the person and all of their health needs. In fact, as recently as 30 years ago, it was believed by the mental health establishment that people with IDD weren't capable of having mental illness, that it didn't exist, which also explains why it's been overlooked for so long. And Kate also mentioned the issue of time, and I think that's a really important one that underplays a lot of the health inequities we see with people with IDD, not just for their mental health, but for their physical health. We don't reimburse providers for the extra time it takes to talk with people that have intellectual developmental disabilities. So a provider seeing Kate or someone just like her that doesn't have intellectual developmental disabilities is given the same 15-minute interview and paid the exact same amount. And what that means, sadly, is that many providers won't even see people with IDD, but when they do, they rush the visit in a way that leaves our athletes and people with IDD in general feeling disrespected, unheard, unseen. I can't tell you how many times as chief health officer I've heard that from our athletes. It really saddens me as a doctor and as a professor at a medical school. I'm very pleased that part of what we do in our healthy athletes, and Kate can tell me if she agrees or not, is we try to provide a very welcoming experience for people with IDD. And equally important, we train other doctors because our health screenings are staffed by volunteer clinicians in all fields of medicine and nursing and physical therapy. And as part of that staffing, they get training and firsthand experience.
So, Dimitri, your study found that it can actually be harder to get mental health care for people with intellectual and developmental disabilities. Is the biggest issue cost, a lack of trained providers, something else?
It's all of the above. It's lack of trained providers, it's cost, it's lack of insurance coverage, and then it's all kinds of other structural barriers, transportation, support, etc.
Kate, how were you able to be treated?
I always have to take my mom with me in order to ensure I get questions answered that I need, because if I don't have somebody with, they don't even take the time to answer my questions. Sometimes physicians will often talk to the caregiver instead of us, but I found that if I go alone, they just kind of ignore my needs and shove me out the door.
Kate, what do you wish doctors, therapists, policymakers understood about mental health and disability?
We need to be included in that conversation. There needs to be changes made to the healthcare system in order to ensure that we receive the care that we need, whether it be make training for med students in school to understand how to work with us, make it part of their required as part of their curriculum, or required as a continuing education requirement for current physicians.
Dimitri, if you could change one thing in the healthcare system tomorrow to improve mental health care for people with intellectual and developmental disabilities, what would it be?
Only one. I'm limited to one change. That's a challenge because there isn't a single fix. But, I'll say this. I will say if more people got to know people like Kayte as the wonderful human she is, whether they're medical students, policymakers, or teachers, they would see Kayte and they would see the world differently. And that alone would motivate the changes that we need.
Is it something about folks with intellectual and developmental disabilities that keeps people from asking about their mental health?
I think it's because they don't think we know how to express their feelings. And sometimes with that happening, we tend to stuff our feelings down and it turns into bigger problems. By the time we get to someplace then that can help us.
So athletes with Special Olympics are supported. How do we get more people supported?
We need to make people aware. We need to create more programs like Strong Minds within the community that help others that aren't connected to Special Olympics learn how to cope and build coping skills and learn how to access healthcare and advocate for their own healthcare.
What helps you take care of your mental health?
As you can see, I have a cat. He keeps walking through the computer. I like to do art. Special Olympics has also been part of that thing. Just because I don't participate in sports, I am still very connected to Special Olympics Minnesota. Through the healthcare programs and through the athlete leadership programs help me to find my voice and help me to become the person I am.
Dimitri, I'm curious where you think we need to go from here.
I think we need to start by recognizing the problem for what it is and not overlooking it. Taking the needs, the mental health needs, as well as the physical needs of people with intellectual and developmental disability seriously and make health equity a priority and ultimately a reality. I want to add that to do that is going to require time and effort, but it's also going to require research. People with intellectual developmental disability have been systematically excluded from research opportunities. In fact, in the last 15 years, 75% of National Institute of Health funded research in the United States has excluded people with IDD, either actively, passively. And what that ends up meaning is that we don't have enough data on treatments, therapies, approaches that work, that meet the special needs of people with IDD. We started a registry, which is to say, we started asking our athletes upon registration at Special Olympics if they would like to learn more about research studies they could potentially participate in. And as of last week, over 11,000 athletes in the United States have said they want to participate in research. And that represents about 35% of our enrollees. And that's actually consistent with what we see in a neurotypical population. So there's a willingness on their part to be part of the solution, and we have to give them the opportunity to do so.
Is it more difficult to determine whether someone has a mental illness under these conditions? Is that what's going on?
I think researchers don't think that we're capable of understanding research and being part of research studies and becoming partners in research, which that needs to change as well. We're perfectly capable. And if they're not, they have guardians that can help them through that.
Dimitri Christakis, Kayte Barton, thank you both so much for joining me.
Thank you for having us again.
Thank you.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmon, and Rachel Walsh. Audio production by Michael Bonfils, Matthew Martin, and Philip Porter, with support from J.B. Arbogast, Spencer Greer, and Chip Hickey. Distribution and social media by Rachel Walsh, with support from Nick Moran and Brianna Iacovelli. Follow us on Instagram and Blue Sky at Public Health Pod for more public health takes and special content. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.